Kevin, our presenter, will address either in the chat or live. In addition, because we are framing this as a discussion, unlike many webinars, we encourage you to come off of mute and jump in and share examples and get involved in the discussion, really to make this an iterative conversation. So with that, I'm going to get us started and introduce our wonderful speaker today. So just first a word about the Angeletti Group. We're excited to be hosting this webinar. It's our first webinar in quite some time, and we're looking forward to rolling out a number of webinars. If you don't know us, we are a full-service philanthropic consulting firm. On the screen right now are just a couple of the things that we focus on, but we do have a comprehensive suite of services, and we're always here to help if you have any questions about how we might partner with your organization. Go to the next slide. So just also one more point about us. Given the topic today, I just wanted to highlight for you our depth of experience with grateful patient and physician engagement programs. We've worked with a lot of the nation's leading healthcare systems and hospitals. I think we might even have a few folks on the meeting today who are from some of the clients that you see here on the screen, but this is just a sampling of some of our recent healthcare focused partnerships lately.
Yeah. And I apologize, we don't have Morristown and Gaylord on here, but I know that there are some folks on here with us from those organizations as well.
Yeah, thanks for being here. So it is my pleasure to introduce Kevin Ralph. I've had the pleasure of working with Kevin for 6 or 7 years now. Kevin is our senior vice president. He comes to the Angeletti Group with 27, right here, 27 years of experience in healthcare and other nonprofit organizations. Kevin uniquely also was a client of the Angeletti Groups when he worked at Matheny and then later in his career at Cape Cod Healthcare. So he's really seen both sides of the desk when it comes to working with the Angeletti Group. So this is really his bread and butter, this type of work and working with physicians and building these types of programs. So we're excited to have him lead us through a discussion about patient and physician engagement.
Great. Thanks a lot, Kate. I really appreciate it. And we have a few members of our team here with us also. If really quickly, Don, I see you on here. Maybe just say a quick hello from the TAG team members who are here.
I have to unmute myself then. Yes, greetings
Yes.
all. Exciting to be here and clearly a vital part of what it means to do healthcare philanthropy. So, Kevin, thanks for leading us today.
Oh, thanks. Thanks, Don. And actually, we have a pretty small group. It looks like we're missing a few people. Why don't we just do quick intros so everybody can hear where we're all from? Michelle, you're really important to this.
Hi, I'm the marketing coordinator for the Angeletti Group, and happy to be part of this first webinar series in a while.
And thanks for everything you did to put this together. And Betsy Cladaris is on our screen here too. Betsy?
Hi, good afternoon. Betsy Cladaris, part of the TAG team, work with clients, content, marketing, a little bit of everything.
Thanks, Betsy. And then we have some other friends. I haven't had the chance to meet everyone, although I have met a few of you here. Joe McAndrew, do you mind just saying a quick hello?
Good afternoon, good morning or afternoon. Joe McAndrew from Gaylord Specialty Healthcare. I am the Senior Philanthropy Officer, Frontline Fundraiser. Been here about 2 years.
Great. A great place.
I'll put my camera on too.
Oh, that's thank you. Oh, Suzanne, I'm sorry, I missed you. Suzanne Alban.
It's because I'm just a distant memory from this morning, I think.
Yeah, I haven't seen you in a while.
Suzanne Albin. I'm a vice president of client partnerships, one of the consultants. Kevin and I are currently working closely together on a healthcare project. So happy to be here as well.
Yes, and that's a great introduction to our Morristown friends. I think we have at least Sukesh, you're on, I believe, right? Oh,
Hey, hello, everybody. Sorry, I was talking while muted.
oh, sorry.
I wasn't expecting to speak, Kevin.
Yeah, I apologize. I didn't mean to put you on the spot. Sorry.
No worries. My name is Sukesh Gill. I'm with Morristown Foundation. I've been here as a director of database management for close to 2 years, and currently working with Kevin on our strategic plan.
Great. Happy to have you here. Thanks for doing this. And I can't see, I know there's others on here, but I'm not seeing anybody else on my list. Gator.
Yeah, so if you haven't introed yourself, maybe just come off mute and intro yourself. I also have the screen share, so I can't see everybody.
There's maybe 2 more attendees if they feel.
Hi, yeah, sure. Hi, my name is Priti Kapoor. I work with Joe at Gaylord. I work with the Grateful Patient Program here at Gaylord. I've been here about 3 years.
Ah,
Excellent.
perfect.
Welcome.
Hi, and I'm Joe Rassiopi. I apologize for not being on video here, just not in front of my computer at the moment. But I work for Robert Wood Johnson University Hospital System. I work as a major gift officer specifically for Newark Beth Israel and Clara Moss Medical Center.
Terrific. Terrific. I think that covers everyone. Great. And sorry, I didn't mean to put you all on the spot, but as our group is pretty intimate here, I thought it was good to go around and introduce ourselves. So this is a big topic, and I've already used up some time here, but as Kate mentioned, some of my background, I've done a lot of work in what used to be the traditional grateful patient and physician engagement space, both in the tertiary and community hospital settings, as well as behavioral health, addiction treatment, and nursing and long-term care. So I've had at least a taste and a feel for how these types of programs can work in different sectors and be tailored for our needs depending where we are. But the idea that here today is really to expand how we think about these types of efforts, and also to learn from each other. So it's actually perfect that we're able to have a manageable sized group here where we can share some ideas and thoughts and questions as well. Again, it's a big topic, and it's complicated if we're doing it the right way. And I'd love to be able to have a chance to follow up on this as well. Certainly offline, and we've already talked about doing deeper dives into specific areas as a follow-up to this webinar as well, where we can really get into the weeds with some programs, specific programs. So just to kick things off, if you've seen one Grateful Patient program, you've seen one Grateful Patient program. That's a take on our principal, Jay Angeletti, says quite often, if you've seen one healthcare system or one healthcare system foundation, you've seen one healthcare system, right? This is a complex world, and while we certainly have models and to a certain extent templates that we work off of, right? You've seen one program, you've seen one, right? Just because we have, we've already talked about Morristown and Gaylord, different types of organizations, right? Different types of approaches to your patients. And that's going to look different from a physician engagement and clinician engagement angle also. You'll see how we start to use the clinical terminology more and more here. And I'm sure you've seen that in our industry in general. But the point is that we can't have a standalone Grateful Patient program without physician engagement. And physician engagement is not going to be maximized if it's not intertwined with a Grateful Patient program. It's not the possibilities won't be fully realized if these aren't completely synced and, use the term, intertwined here. To do this right, we have to approach these together. So expanding our definitions. What is this, right? So obviously, at the end of the day, yes, for us as advancement and development professionals, the idea is for us to raise more money, right? But what are we offering our patients and the people that we serve? And that's a meaningful way to express their gratitude. We're going to talk about gratitude in a second here. But from a physician perspective, we're also going to be looking at them and have been looking at them as donors as well, right? This is a a different landscape than we had in 30, 40 years ago, right? When physician philanthropy was at a different place than it is right now, where we relied much more. If you look at percentages of physician giving, again, going back several decades, as components of or as parts of campaigns, you can see much bigger percentages of that happening. But that's not to say that physicians can't be important partners on the philanthropy side as well in terms of their own giving or giving from their groups or practices. And again, how are we recognizing those who are our most supportive donors? The third bullet here, we talk about acknowledging, recognizing donors, but how are we treating them? How are we communicating with them? With the understanding that there's never two tiers to healthcare delivery, right? No one is ever getting pushed in front of the line because they're a donor. But how do we talk to them about their importance to our healthcare organizations, and how is that reflected in the way we go about building our relationships and stewarding our relationships with them as well? And finally, this grateful patient work, physician engagement work, this is an expansion of everything else that's happened, right? This isn't a standalone program. So there's elements here that are obviously major gift oriented, planned giving oriented, direct response, and annual giving oriented. So this isn't a standalone project or area of focus that is off to the side. It's integrated and should be fully integrated in everything else that we're doing in our shops. So why are we focusing on this, right? Well, we know that organizations that take this type of targeted approach to again, cultivation and stewardship strategies, they're going to raise somewhere between a quarter and a third of their charitable giving revenue is going to come as a result of these programs. So if you're in a place where you have something like this now, what are the opportunities to grow and enhance? If we're at a real starting point, where do we begin? And for some organizations who are, have been at this for a while, who have, highly tailored metrics and plans, what can they do to improve as well? And we'll get into that in a more detail in a minute here. But again, why is this all important? And regardless, this theme, I mean, this is what we do, right? This is what we do as fundraisers. We work with people, we work with organizations and foundations who are committed to what we're doing, to our case, to our cause, and understanding how important that the gratefulness and the aspect of gratitude and the role that gratitude plays in all this is absolutely essential. When we think about it, I've spent time obviously working in higher education, in humanitarian services fundraising, and healthcare. We're really in a pretty distinct place here when we're thinking about the impact that the people we work with have on the lives of our donors, right? There's literally transformational, in some cases, life-saving, life-altering interactions that our donors have with our organization. So it's powerful stuff. It needs to be handled properly and in many cases extremely sensitively. But there's a reason that we do it, and there's a reason that we approach that, and that's this string of gratitude that runs throughout again the course of all the work that we do. So types of organizations. So I have an example later if we have enough time, where we'll walk through a basic standing up a program and getting the basic nuts and bolts started in a hospital or medical center situation. But again, thinking about what I talked about earlier, healthcare systems, hospitals and medical centers, nursing, long-term care. There's a variety of different types of organizations that can go about this work in a really meaningful way, obviously tailored, highly tailored and highly structured to meet your specific needs. But let's cast a wide net, right? Most of us aren't going to stay at the same organization. I certainly didn't during the course of my frontline fundraising career. so this is it's certainly valuable for us as professionals to understand how the nuts and bolts of how this works, how this all works, right? But again, how do we apply that to the various steps or stops in our journeys that we're taking along the way? And we should not rule out the impact that this type of focused work can have just because we're not in a quote unquote traditional healthcare setting. And grateful patients, right? Going back to that terminology of grateful patients. Well, who are our grateful patients, right? So we have the traditional inpatients, outpatients, but not everybody refers to the people they care for as patients, right? Working in the behavioral health space or the addiction services space. Sometimes we're talking about patients or we're talking about clients. In the scope of nursing, we're talking about residents. Sometimes and rehabilitation. Obviously, there are organizations that combine a lot of these different elements. And really, let's not forget about families, right? Families are extremely important to this. It's not just as with all giving, with all charitable giving, but when we're approaching this from the perspective of working with our donors, families are really, really key because they're feeling the impact here as well. Again, whether it's positive outcomes that are a result of a loved one who had to get transported into the emergency room overnight for a heart issue, or it's a loved one who did inpatient addiction treatment. And because of that treatment, their lives are completely different. Not only the individuals, but the lives of their families and friends are impacted, right? So let's think about that if we're not. And I'm not. I guess it may sound like I'm assuming you don't think this way, but we're going to get to a point. I'd like to get your feedback and take on this in a minute. But again, thinking outside the scope of the traditional inpatient and outpatient model. So same applies for our clinicians, right? So use the term clinicians as opposed to physicians. And I know obviously we're not the first ones to do that. This is fairly or becoming more and more common now in our world. But who are they, right? So we certainly know the doctor model, right? Doctors and physicians. But let's also think about all the other people who deliver care, who are so important and oftentimes develop the most the closest relationships with patients, clients, and donors, nurses, nurse practitioners, therapists, behavioral health professionals, and in the research world, those who are finding cures, right? There's no reason that this model cannot be adapted. And again, I know we're not obviously the first to approach this concept, but if I'm a disease-specific organization, for example, how am I approaching my work, and am I thinking about our donors through this lens of grateful patient giving? So before we go on, I told Michelle that I wasn't just going to talk, so love to hear some thoughts or comments just as we're getting started off here. And my TAG colleagues, please feel free to jump in. Just so everyone knows, they haven't had the benefit of seeing this yet, so they're seeing this for the first time too. So if they ask questions, they're genuine questions. They're not plants.
Well, one of the great issues that always arises, Kevin, is the whole reality of HIPAA in the healthcare environment. Will you touch on that perhaps in the emerging slide here?
Definitely. That's a great point, and I have some examples for that later in here as well. But HIPAA, and I don't know what all of your experience is like, but the idea of HIPAA won't let us do that, right? I mean, how many times have we heard that phrase?
Right.
And I think that when HIPAA first came into effect, and it was new and scary for many people, because we didn't understand what the ramifications were, right? And we've certainly seen some organizations get their hands slapped for non-compliance or for some issues. But yeah, definitely an important point. We'll touch on that a little bit, but related to that theme, I would say don't be scared of HIPAA. It can be scary, but it shouldn't be a roadblock to what we do here. And there's more than enough work that's been done in our industry that we can learn from mistakes of others. But really, there's a lot that we can do. I'd love to get this group's feedback on that in a minute here too. Your own experiences around HIPAA and compliance issues. But just really briefly, what we're going to look at in a second here are the components. So the concept here was scalability, right? That was the theme of this session, scalability. So where are we both, on the spectrum here in terms of our development, our aspirations, and how do we take these key components that are really going to make these programs effective and apply them to our situations and to our aspirant situations as well. We talked about the size of your organization. We're not going to say it doesn't matter, but it shouldn't determine the potential that your program has, right? I know of plenty of hospitals, larger sized hospitals that don't do any work in this space, right? They either don't have the bandwidth, the staffing resources, or just philosophically don't think that this is going to work for them, right? So just because we have a big medical center doesn't mean that we have a great physician engagement and grateful patient program. So that shouldn't be, I guess it's the same theme as we're talking about HIPAA. Don't let that shouldn't scare us off as fundraisers. And again, that's the theme of tailoring. What is our opportunity? And there are going to be certain cases where, as much as we'd like to make it work, this just isn't the right strategy for our organization, right? We either don't have the donors, we don't have the potential, and if that's the case, then by all means, we should not twist ourselves into knots trying to make something work that's not a good fit. But in the cases where it does make sense and it should work, that's what we're addressing here today. All right, so we're gonna. This is where we'd love to get the discussion going. This one slide, there's going to be a lot on here. Start with our startup. So again, going back to these phases on the last slide, in the startup phase, what are the absolute basics that we want to have as we're ramping up an effort? And this is working on the assumption that we have caregivers, right? We have physicians, we have clinicians, and we have patients or clients. That's going to be assumed throughout here. But first and foremost, do we have a compelling case for support? Right? Just like we would talk about developing any fundraising strategy, what is our case? And what is the specific case for our circumstances? And that's obviously going to look different for each of us, but we need the case. We need the case for support. And we need someone to do the work. Who's going to be responsible for this ultimately? I've seen these programs where we've had, half of a person's job in major gifts is going to pay attention to this. And then we're going to have somebody on the stewardship side handle maybe a quarter, and it gets blurry and never gets off the ground, right? Because no one's fully committed. And when I say that, it doesn't mean you need to have a 100% dedicated FTE specifically to this, but we need to have, we actually had used the term dedicated staff. That doesn't speak to their dedication to the organization. It means that they're dedicated to the specific task at hand. So who's going to own this? Who's going to own this? Who has the time and capacity to take this on? And of course, we need a plan. We need, which we'll talk about developing here. What kind of data do we have? That looks different for many of us as well. So we know that we are providing service. We know we're providing clinical care. What does our data tell us, and what data do we have access to from the medical record side, for example? So data, as is with everything we do, data is absolutely key and at the core of all of this work if we're going to be doing it properly and strategically. And then basically giving vehicles. Okay, maybe that maybe that's an obvious one, right? But we need ways for people to give. We need and how are we communicating that? These aren't all going to be major gift asks, but how are we enabling people to support our organizations on a regular basis, and are getting into things like sustainer programs. We're not going to have time to get into real detail with all this today, but the point is we need to be able to give people an avenue to give. And I throw this. I don't think we have any planned give. Do we have any planned giving folks on the call?
No.
I mean, we're all obviously familiar, and those of us who have done a lot of major gift work are probably more dangerous than others with planned giving, right? But I can't, and I'm not my background prior to being an administrator was mainly in the major gift space. So my expertise on the planned giving side goes so far, but we have to have this at the very beginning. We have to have this planned giving component available. It ties into the giving vehicles, but this has to be available and present. And especially when we're looking at smaller organizations or organizations that might fall outside, again, of the traditional hospital medical center setting. And I preach this to the clients I work with now. We have to have, this is an opportunity for transformational gifts. And I've seen it happen with small organizations just in the past year, where 3 of them that I work with have received 7-figure gifts that basically accounted for 50% of what their annual operating budgets would be. And they were planned gifts, and they didn't do a heck of a lot from a staff perspective to other than providing good cultivation and stewardship. But just having these, having the planned giving platform available is key. Don, I don't know if you have any comments on that. I know we've talked about this before in the past too, the importance of.
And I think you're going to touch on HIPAA too, because really there's an a priori, there's something that probably comes before data. If you've got medical records, then you need permission to be able to, to use it, for sure.
Yeah.
So there is a little bit of a even before before this. But as far as gift planning, absolutely. We make it so complicated, and we know that something like 80 or 85% of all what we call planned gifts are wills and testamentary gifts. And the next largest category is really pretty straightforward, which is charitable gift annuities. And especially in today's environment, where people are looking for guaranteed steady income, and they're concerned about the market and so on. Those two right there are simple and ways to give.
Absolutely. And your point on data is a good one. And the HIPAA and medical record stuff, that's all under those 4 simple letters of data for right now. Because we could spend again another session on that, but we'll definitely dive into that a little more in a few minutes here. All right, so now we're emerging, and so on top of the points in under the startup category, now we're growing our program, right? And what are the next key elements that we want to layer on top of this? And certainly clinical and leadership buy-in and coaching, and leadership meaning executive leadership, your CEO, your volunteer leadership, your board members, especially if we're talking about implementing any type of concierge type programming. I mean, in many of those cases, your board members are going to be a great pilot group to work the kinks out of those kind of things, if that's something that you're going to look towards doing. To Don's point, policies and compliance, right? A major issue, and can be a major roadblock if we're not attacking that the right way. And it's also a way, again, when we get into our example, we can make this a lot less scary for the clinical people too, for the docs, for the counselors, for the nurse managers. But again, policies and compliance are a topic that's really important here. I just mentioned affinity and concierge programming. I happen to have experience working. I can't take credit for putting the program in place. But when I was at Cape Cod Healthcare, we had a program. It was our Light Keepers Society, which was initially instituted by off the idea of a board member. Now that was over 20 years ago now. And again, this goes back to my point about not having. There's no two tiers of healthcare delivery, but there is a way that we can thank and provide support for those people who are being most generous to us and who are providing the resources that gave us new facilities that everybody benefited from, right? Everybody who came through the door, and that the model works. But again, we talk about making something highly tailored. It's really, really important that this piece is handled with the utmost sensitivity to start with. And really has to be strategically implemented as to not give off the wrong impression of what these types of programs mean or provide. So data analytics, wealth screening, right? We know, just as major gift people and those who do annual fund work, critical to guiding what we do. Where are our greatest opportunities? And we'll talk a little bit about wealth screening and how often it happens or doesn't happen in a traditional hospital setting, for example. Metrics for gift officers. Okay, so obviously we have our visit metrics, our substantive engagement metrics with our donors, and in this case with patients. But as we do more work with physicians and with our clinical people, what do our metrics look like on that end as well? If I am a major gift officer with my local health system, how am I being judged? Don is my VP, and I'm reporting to him every month. How many doctor's visits did I have? How many visits did I have with other clinical teams to help educate them on this program, on this specific type of program, and again, bringing them along with us through the process. Talked about planned giving, expanding that, looking at resources. Do we require having more staff? Is someone monitoring our the hotline number, I say in quotes, that we provide to members of our Grateful Patient Program? What are those resources look like? What do we need? And you'll see later also, what can we afford? Right? What can we afford to do, and what can we afford not to do in order not to leave opportunity on the table? And then how does this tie into direct response strategies? And I get into a little more detail with that in the final point here, but where we talked about multi-channel communications and marketing. So yes, we in most cases, or in many cases, we have the major gift level prospects that our gift officers are working with, or that we're working with as development officers, throughout the course of our portfolio management. But how is our interaction then being coordinated with our email, our direct mail, our hard mail that we're sending out, our publications, invitations to events, et cetera, right? So in that advanced column, we're taking that to a new level, and we're also able to measure our impact a lot more as well in terms of responses and outcomes that we're seeing related to that piece. And I won't go into too much detail here, but some things, high touch involvement from executive leadership. How often is our CEO or our hospital president or our organization's president being involved? Again, what do our affinity programs look like? Where do we need to make adjustments, and where's there opportunity there for additional growth? I mentioned executive health initiatives. I'm sure some of you, if not all of you, are familiar with, in this case, larger organizations. Think of some New York City, Boston type of well-known institutions that are providing executive. I'm using the term executive health initiatives here, but essentially screenings for their high-end leadership donors who are looking to have not only a health assessment done, but to be really closely linked up with physicians and doctors who can help put their plan together, sort of outside of the normal scope of a doctor's visit, right? So it's more formalizing this executive health, the idea of an executive health type of a plan that again treats people in this way that lets them know that they're appreciated, right, and they're really valued because of the support that they offer. Already touched on major gift metrics and the multi-channel communication. Again, ensuring compliance with information systems with our medical records colleagues, and then the regular measurement in program enhancement and ongoing coaching and staffing. This isn't something that or staff engagement rather. This isn't something that we introduce. We go around and talk to all of our department heads and board members and get them up to speed, and then it's done. It's like with any good board development work. Maybe we do a retreat. We do something that introduces the concept of coaching and board development training, but that's got to happen continually. There's got to be an element of that throughout the course of a year, so that and certainly as programs evolve and grow, or maintain and just get better where you are, there's always going to be need for again, constant communication and refreshment on the coaching and the education and learning side, I would say. So, sorry, again, I've talked a lot. I'd love to throw, just open things up here and talk a little bit about what you're all seeing. What are where do some of you fall in this on this scale here, and what are maybe some particular challenges you might be facing or questions that you have? I won't put anybody on the spot. We can keep going.
So I guess for one of the, at least securing grateful patient gifts is trying to keep them, giving, right? So
Right.
they get discharged, they are grateful, they donate in recognition of a clinician, and then year two, we're kind of a distant memory. So trying to secure some of that sometimes can be challenging.
Sure. And that's really a function of how, so we've had the engagement, the initial engagement, and obviously our hope is that folks don't have to keep coming back to us, right, in terms of any specific incident. But in order to move, and this is where our wealth screening really comes into play, right? So we're not going to be able to touch everybody, but for those who have high capacity identified through our wealth screening, how do we take them and move them from that initial touch, right? As you mentioned, Pretty, the gift in honor of, right, in honor of a physician, and if we see someone has, with the understanding that we know wealth screening isn't perfect, but if someone has a gift capacity of $500,000 to $1 million, we're gonna put them on a track with the major gift team, or the people, or the person or people responsible for this. And I think that's where they really, okay. So we know they're at least interested and at least grateful, right? And we know they have capacity based on what the data tells us.
Right.
And how do we get them now into our pipeline for real major gift stewardship? But again, that speaks to our resources too. So,
Right. Yeah.
like knowing what I had done some work with Gaylord a few years back, and again, you don't have an army of fundraisers. Is that fair to say?
Correct. It's myself, Joe, and we have an events person and a grant writer. So there's not that many. So it's yeah, it could be a lot for Joe and I.
Yeah. Yeah. So really in that, in your prospect pipeline, where, that's really up to you to decide where, how great is the opportunity and where does that fall in with all the other opportunities that you have? Because with your example, it's really going to be a matter. There's going to be hands-on work that has to take place, right? It's fine to have this multi-channel approach and follow up, but you have to prioritize and you have to obviously map out your prospect pipeline to work accordingly.
Of course, yep.
Um,
Joe and I work closely together with that, and we do some great stewardship events when they do make a gift in honor of a clinician. So we're
yes.
stewarding properly. It's just the follow up after that could be challenging.
No, absolutely. I know exactly what you're saying, and you're in a bit of a unique place too, right? Because of the type of organization you are. So for those of you who don't know on the call, Gaylord is a specialty hospital and rehabilitation hospital. So they're not going to see they don't have an emergency room, right? They're not going to have people walking through their front door as an introduction as a matter of necessity, right? So this goes back to the theme of tailoring our approaches, because folks are getting introduced to you in a different way. I'm going there for PT. I'm in because I had a traumatic brain injury and I'm going to spend some significant time with you, right? So I may not be coming back as often, but the impact that you have may be a lot greater than an interaction I would have with a general hospital, right? Type of a setting. So how do you, and I know I'm sure every single day you talk about this, right? And think about how you engage people properly and strategically in that manner. But
And at what point in their stay? Our stay generally about 30 days is our average stay.
right.
So at
Yeah,
what
I was
point?
curious if there were any cold calling or rounding strategies that you've all encountered. Because Pretty and I do some rounding. Pretty does the majority of them, and how do you introduce yourself, or like what are some of those strategies just to get to know the patient, if you will, without letting them know, that a little bit of their background. That's always kind of something I struggle with.
100%. And you know what? I'm going to jump ahead. I said we were short on time, but I didn't realize it was going to be this short. But Joe, I'll answer that question in 1 minute. Let me just cover this slide quickly, talking about the balance, just because it relates to the slide we were just looking at. So if we're an early stage program, so we see where physician and patient is highlighted over here. Think about the physician or clinical person on this scale and their importance. We've done quite a bit of work recently with federally qualified health centers, and I'm working with a hospital in New Jersey, a large safety net hospital, where their physicians right now are their best prospects, right? It's a growing organization. They have a diverse group of physicians who have trained in New York City, who have gone over to northern New Jersey to start their careers or in mid-career. And right now, they're some of the best prospects that are there, right? So we're treating them in this way as donors themselves, and not that we wouldn't do that throughout the course of time, right? We do want to have physicians move to the engagement piece, and how they're helping us interact with patients. But I think it's really important in some of our situations to remember that the clinical people, and again, dollars, we're not necessarily talking about even 6 or 7 figure type gifts, but the capacity that your clinical group or your physician groups have can help move the needle in terms of percentage of your total revenue every year, right? Quite a bit. And I know in some of our cases, if we can raise an extra $500,000, that's really going to be impactful. So it's about impact and it's about the role here. That's why I'm talking about the focus on patient giving. Obviously is always going to be there. There's a grateful patient program. We want to take them from an initial gift. So from that Pretty, from your example, from that example of making an honorary gift in the name of their caretaker, increasing that over time, and then even having our patients become advocates for us as well, right? Whether we're highlighting them in profiles and solicitations, asking them to bring others into the fold as we would in a campaign setting. So again, it's this balance of where are we in terms of those steps that we just talked about, and what are the roles and expectations of everybody here.
Right. And how much time do you spend stewarding $100 donor, right? How much effort do you put into that?
Exactly. And that's one of the hardest things we do, right? I mean, I remember being a young gift officer a long time ago, and having 250 names in my portfolio, knowing I could only get to probably half of them, right? But darn it, I wasn't going to give up these names,
Right.
because even though they only made $100 gift, the darn well screening is telling me that they can do 1 million, right? And I've tried, and our CEO
Right.
or president has tried. And at some point, we just have to let go, as much as it hurts. And with different organizations, I've called them different things. We put them in our parking lot or our pool, and when the time comes around to revisit them, when we have all the resources that we want in a perfect world, we'll do that. But we can't forsake the attention that we need to give to those who are involved and who have high potential and high capacity, because we're trying to do too much, right? Because we're not going to let go of just what's not happening at the moment.
Thank you for your input.
Oh, of course. And let me jump ahead. So these elements, talking about where we are, and whether we're starting a program or enhancing a program and making it more highly evolved. Obviously, assessment and program design, the actual implementation and enhancement of a program, and then sustainability and growth. And these are the steps. I'm not going to go through them. I want to get to the point about rounding that Joe brought up. But again, hey, not rocket science, right? I guess I've always said that, I got involved with this in our business 30 years ago completely by accident. I was going to be a college basketball coach. So I was an assistant coach at my alma mater, Division III, Drew University in Madison, New Jersey, and I wanted to be a basketball coach. I got to do that as an assistant for a few years after I was done playing, and then a guy named Jay Angeletti became the VP of the place, and he needed some people he could put out on the road and who knew how to talk about the school. So that was that was me, and I was going to make more than $3,000 a year doing it. Not much more, but that was my introduction to this world. So my point is that none of the stuff we're talking about here or laying out it's not rocket science, right? But there are really key elements here that take discipline to follow and to implement. And once implemented, we need to have the ability to go back and reflect on and assess and measure the work that we've done. So again, without diving into all these bullet points here, this is essentially another way of looking at the growth of and sustainability of a program. So here's our example, and want to be sensitive. We have 8 minutes left here, so. As an example, we're starting this with an unnamed hospital. So we're looking at this very, very generically. What are some of again, getting into a little bit more detail here? How are we going to get this thing started, or what are the elements that we need to really make this work, right? And so we definitely need buy-in. We need buy-in from physicians. We absolutely need buy-in from nursing and nurse leadership, nurse managers, clinical managers, right? Counselors, et cetera. Who are going to be our champions? I've worked with physicians I knew were completely on board, and they were going to go hand in hand with us down this road. And there were others who wanted absolutely nothing to do with anything that smelled like this, right? So how do we identify those champions and work with them and again, bring them along with the education and resources they need. But it's beyond that. It's also, we're building relationships, right? Just like what we do with our donors. These internal relationships are absolutely key, and our clinical people need to feel comfortable working with us. This is a little bit more detail there, where we talk about the multi-level support. How do we get out how do we properly get out the idea, the concept of the work, this type of work that we're doing, so that there isn't this idea that, oh, well, we're going to push so and so to the front of the line, or they're going to get special treatment. Because obviously, especially with new programs, but I've seen this with programs that are well established. You have either new people on the clinical team or folks on the clinical team who haven't been involved with this type of work in the past. There's a lot of room for misinterpretation of what this looks like, right? So there's again that education piece, and going back to Don's point, the legal and privacy pieces that we're going to get into here. I promise you, I keep saying that. Let me just do it. All right. The data you need and can get. Here you go, Don. So talking about HIPAA, and I have a separate piece on this that we can really dive into, or again, if anyone wants to follow up, I'm happy to get into a more detailed discussion. But as long as we're not getting deep into either diagnoses or personal health information that is prohibited by HIPAA and by the federal government, I mean, there's a lot we can get, and a lot we can use in terms of just general wealth screening. We get names, we get addresses, birth dates, phone numbers. Although I know, we're not looking at this from a telemarketing perspective, but for us as fundraisers, obviously, the more contact information, the better. We can know the dates of service. We can know the service line that they, and the doctor who they interacted with. So there's a lot that we are allowed to know by HIPAA. But then, of course, we also have our own institutional and organizational rules that we have to work with too. So whether you have in-house legal counsel or however your governance structure works, it's key from both aspects, right? So we have the HIPAA piece, but then we also have, just because HIPAA allows us to do something doesn't necessarily mean that our own organization will want to allow the same level of information or detail out. And we again, and depending on our organization, who are we going to screen out? Obviously, if I'm working in the behavioral health or addiction space, I'm not going to suppress the names of folks who are receiving addiction treatment. That's my base, right? But let's say in a tertiary setting, there may be reasons that you want to suppress behavioral health or certain oncology patients. We could go down a list of what works and what doesn't work for different organizations. But the idea is that this is not a one-size-fit-all approach, right? We have to really tailor this, and especially when we're dealing with the PHI and the information that comes along with that. Don, am I missing anything without getting too?
No, and it's wonderful what you covered is that, so many people bring up HIPAA as a well, we can't do that. And in actual fact, as you say, a good deal of the data is legitimate.
Yep.
It leads to a question though, Kevin.
Kevin.
Someone suggested that in the field that it's important to have a dedicated database or to have a way of being sure that you don't intermingle medical records with donor records, which in the CRM world. You want to comment on that?
Yeah, actually, Sukesh, do you want to? You were trying to make a comment too. I think you might be able to comment on Don's point.
It's kind of related to what Don was saying about trying to collect any sort of medical related data points from the hospital side. So obviously we cannot get that, right? So another thing I was thinking, and I wanted to get your take on if you've ever experienced this with your clients, is it possible, or have you seen foundations getting a data point in terms of patient's experience? So let's say if I were to just classify my experience as, great, not so great, never coming back here again.
Yes.
That will be a great data point. Unfortunately, at our foundation, I've been kind of trying to look for that because
Yeah.
that will be a great exclusion point. Like, folks who did not have a great experience with you, don't want to come back to your hospital, might as well just exclude them. Have you experienced that?
Yes, absolutely. And two things there. One on the patient satisfaction side. So we can see press Ganey results, right? In general terms, what those are telling us in terms of patient satisfaction, right? But if you have a patient experience, which almost I'm sure you do, right, at Morristown, but a patient experience office or point person, that was one of the closest relationships that I made. And oftentimes, well, between patient experience and then the CEO suite, I would say, we set up a system so that anytime we received direct feedback, so I got plenty of nasty letters sent to me as a result of direct mail that went out, but certainly the CEO and our patient experience person were hearing the brunt of that. And the idea was that they would just share that information with us directly with the foundation team so that we could then identify in our records, right? And with our major gift team or whoever's working with said donor, that we can integrate that type of feedback into our approach. So it wasn't necessarily, we weren't able to drill down into press Ganey survey information to get those identifying markers for individuals, but we could do it with an internal process. Again, in my case, it was between the CEO's office and patient experience people, and being in front of them. Obviously, the CEO is in front of all the time, but patient experience, I was making it a habit to at least stop by there or interact with them once a week to hear what the latest and greatest was. For them to have us on speed dial too, because they'll certainly hear and see things that nobody else hears or sees, as part of the organization. So I get a little more informal, but it's a way to get that information over to you guys on the foundation side for sure.
Got it. Okay. Thanks, Kevin.
Sure. Oh, and we're already over 1:31. And obviously if anyone has to go, you can go, but let's see. Oh, okay. Here's where we touch on rounding a little bit. And another, so we talk here about rounding based on, in this example that I was going to go through, this is based on essentially daily wealth screening. And so I see that we have a high capacity donor who's on the med surg floor. I'm going to go over and visit. What does the process look like for that? And in many cases, this goes back to what type of relationship do you have with the nursing team and the nurse managers, right? It better not be, oh no, here comes Kevin from the foundation, right? Yes, it's Kevin from the foundation, but I don't want them to say, oh no, right? I want to have that relationship where they're going to feel comfortable with me or members of my team coming around to do rounding. And again, we can handle this different ways. And in some cases, you'll see, or your organizations do, have a note card come from the CEO with a patient's meal. There's ways to do this, to introduce the relationship in a way that's comfortable. But actually, in my last job on the front line, our CEO had all of the senior team round. So it didn't matter if I was the chief development officer and senior VP, the chief financial officer, everybody in that C-suite, we were all responsible for rounding. So for me showing up in a patient's room it didn't look out of the ordinary. right? And we weren't trying to pull a fast one on anybody either. I mean, that had a lot to do with patient satisfaction in general. But if I know that as the head of the foundation, I'm going around and I'm doing my weekly rounding or daily rounding because I've been alerted that I should get over and visit with Mr. Smith on the med surg floor, right? It's not going to be odd for me to show up. And in those visits, very transparent that I'm from the foundation, want to check in to see how you're doing. Are you comfortable? Nothing that, and I can share I can share some more details around this strategy with the group as well. But the idea is we're certainly not going in there and asking them for money. And it's not unusual for a senior administrator to be coming around and doing rounding with patients. So it becomes part of the culture, right? It becomes natural. And then again, the clinical team, the nurse managers, the folks on the floor feel comfortable with you too. And it works. I mean, I've done this and I've seen it work. I've definitely run into some roadblocks and have been in some awkward situations. But overall it works. And if we don't do it, if we don't stand firm with our strategy and our approach as fundraisers, we're kind of selling ourselves a bit short, not using all the tools in our toolbox. And again, I'll just mention also before we conclude that these programs can be so important, not only for your annual revenue, right? You're going to have, if we're diving deep into an affinity program where we have a dollar threshold, I'm making this up, $10,000, you're going to be part of our XYZ society. Yeah, that's important, right? And we talk about moving donors through and up the pipeline. But in my last stop, we were raising roughly $2 million, give or take, a year through our Grateful Patient program. But if you look, we did an analysis. We were about 10 years in at that point in time, and had gotten that up to, again, roughly a $2 million revenue mark as part of our overall fundraising results. But if you look at the group of people who were giving that $2 million a year, they ended up at $82 million a year in lifetime giving, big campaign gifts, some bequests and planned gifts. I mean, so yes, it was about the here and now and about the short-term wins and the important revenue that we know we all need, right? But there's also the bigger picture and the bigger prize, I'll say, when we look at capacity and what impact can really be out of this group if we care and nurture them the proper way. So
thank you.
No, thanks. I apologize for running over.
No, you went fast.
Good
yeah,
stuff,
a
Kevin.
lot faster than I thought. So
Yeah.
Sorry, I rushed through a few things, but
Wow.
again, I'd love to. You can see everything we missed really quickly, but my contact information is here. Michelle, does everybody have that also, or?
Yeah, and I say thank you, Kevin. You really did a great job. Some of our attendees are already complimenting you and saying this is great,
Thanks.
great feedback. Yeah, so what will happen, I will definitely reach out to attendees with these slides. We'll post the recording. And then obviously we wanted to mention here, we do have one more upcoming webinar. It's broader about Chat GPT prompts and how they can apply to fundraising professionals. And that will be led by Kate Hughes. But Kevin, you really did do fantastic. And I did see we had maybe a hand up. So you can stay on if you have time, Kevin.
Yeah, I can stay on. But yeah, absolutely.
But
but again, if anybody, if you want to reach out, don't hesitate to call or text or email. I'm happy to follow up also.
And Kevin, the slides you showed today are a slight update, I think, from what you shared with some of us previously. So
Yeah.
if you get this current version out, I think folks will appreciate it.
Yeah, that's right. I did. Yeah, I made a few tweaks this morning, actually. So as Michelle knows. So
I thought so.
There's always breaking news in our world.
Yeah,
right?
there you go.
Well, like you
Great
mentioned,
job. Appreciate it.
many types of organizations, many types of ways you can establish programs like this, and there's many factors and variables to consider. So it's hard to encapsulate that all into one PowerPoint presentation, but
Right.
you think you did a great job. So
Terrific.
thanks to everybody for attending. We really appreciate your time today. But yeah, Kevin, if you're willing to stay and answer any questions.
Yeah, sure thing.
All right, I will stop the recording.
All right, and thanks everyone who's taken off. If it's not all